It's time for the 3-question warm for Immunology 6. Let's get going. What gives rise to the jugular venous A, C, and V waves? So remember, the A wave is atrial contraction, the C wave is ventricular contraction, and the V wave is atrial filling against the closed tricuspid valve. Next question. Which heart murmur is associated with weak pulses? So this is aortic stenosis. Sometimes this is called pulsus parvus et tardus, which is Latin for weak and delayed pulses. Next question. What findings are associated with Ehlers-Danlos syndrome? So depending on the types of collagen that are affected, you can see things like easy bleeding or bruising. You can have hyperextensible skin. You can have joint hypermobility. And because of all this, there might be dislocated joints. That could also be aneurysms like aortic aneurysms or Barry aneurysms as well. All right, that's it for the world. Let's get to that lecture now.
In this video, we're going to discuss hypersensitivity and complement, which is just about as exciting as it sounds, but it is high yield. For instance, hypersensitivity reactions are at least 4 stars, possibly 5 stars. There are 4 basic types of hypersensitivity reactions, which are called types 1, 2, 3, and 4. Type 1 hypersensitivity occurs when some free antigen binds to IgE on the surface of pre-sensitized mast cells and basophils, and that causes those mast cells and basophils to degranulate and release preformed granules of vasoactive chemicals like histamine and bradykinin. These are vasoactive amines, so they cause vasodilation and they cause increased vascular permeability, which allows fluid to leave the vessels and get into the tissue, which leads to local edema. Now, this is called a wheal and flare reaction, or urticaria, which is commonly called hives. And because these vasoactive amines are preformed, this reaction can occur very, very rapidly. Anaphylaxis would be a good example of a type 1 hypersensitivity, like an anaphylactic reaction to a bee sting or to peanuts or other foods. So technically speaking, if you say someone is allergic to a medication or to a food, you're talking about an IgE-mediated phenomenon. If they have a reaction to a food or medication, but it's not IgE-mediated, you shouldn't really call it an allergy. You might say they're sensitive to it, but they aren't technically allergic to it. Another example would be atopic disorders such as asthma, hay fever, or allergic rhinitis, and eczema. Even though eczema does have a T-cell component to it, it's still considered a type 1 hypersensitivity. To test for type 1 hypersensitivity, if you want to determine whether a patient's allergic to something, you can do a skin test or a scratch test. It's usually done by allergists. So they prick the skin on the back with a needle a bunch of times, and then they put a bunch of common allergens into those needle holes, and then they watch to see if the patient develops urticaria. Remember, type 1 hypersensitivity occurs fairly rapidly, so the urticaria develops within about 15 minutes. Type 2 hypersensitivity occurs when there are antibodies against cellular antigens. So antibodies bind to cellular antigens and activate the immune response. So this might lead to complement-mediated damage, or the macrophages may phagocytose the cells, or NK cells may attack and destroy those antibody-coated cells. But the main thing to remember is that it started with antibodies against cellular antigens. Specific examples of type 2 hypersensitivity would include autoimmune hemolytic anemia, where you make autoantibodies that attack your own red cells. Another example of hemolysis caused by type 2 hypersensitivity would be an acute hemolytic transfusion reaction, where the patient has type A blood and you accidentally transfuse type B red cells. And the patient's anti-B antibodies will attack the B surface antigens on those donor red cells. There's also erythroblastosis fetalis, where a pregnant woman's IgG antibodies cross the placenta and attack the fetus's red cells. In ITP, or immune thrombocytopenia, there are autoantibodies that attack the platelets instead of attacking the red cells. Another type of anemia caused by type 2 hypersensitivity is pernicious anemia, where the autoantibodies attack the parietal cells of the stomach, which produce intrinsic factor, or possibly autoantibodies against intrinsic factor itself. Now, without intrinsic factor, the patient can't absorb vitamin B12 in the terminal ileum, and that leads to vitamin B12 deficiency, which causes anemia and also peripheral neuropathy. Myasthenia gravis is a disease where there are autoantibodies directed against the acetylcholine receptors at the neuromuscular junction. Another neuromuscular disease caused by antibodies against cellular antigens is Guillain-Barré syndrome, in which there are autoantibodies against the Schwann cells, which leads to demyelination of peripheral nerves. Graves' disease occurs due to autoantibodies against the TSH receptors. In pemphigus vulgaris, you have antibodies against desmosomes, or the protein desmoglein. And then bullous pemphigoid is caused by antibodies against the hemidesmosomes. Goodpasture syndrome is where you have antibodies against the glomerular basement membrane. And acute rheumatic fever is a hypersensitivity in which the antibodies against group A strep start attacking the host. Now let's talk about type 3 hypersensitivity. Type 3 hypersensitivity is when there are antibodies against soluble antigens. Not cellular antigens like we saw in type 2 hypersensitivity, but free-floating antigens that are dissolved in the blood. So these antibodies bind to these soluble antigens and they form antibody-antigen complexes that then get deposited in tissues. So it's not antibodies attacking cells that cause the problem. Here we're talking about antibody-antigen complexes that get into the tissues. And again, these immune complexes evoke an immune response with activation of complement and recruitment of neutrophils, and ultimately you get a lot of tissue damage. Now, examples of type 3 hypersensitivity reactions include lupus, rheumatoid arthritis, polyarteritis nodosa, and post-streptococcal glomerulonephritis. Another classic example is serum sickness. So when you hear serum sickness, I want you to think antibody-mediated drug reaction. In serum sickness, you produce antibodies to foreign antigens like drugs. Most drugs aren't proteins, but the drug acts as a hapten, which is a molecule that gets bound to a carrier protein, and then that hapten protein complex can bind to antibodies and form immune complexes. So again, serum sickness is an antibody-mediated drug reaction. Now it's called serum sickness because back in the pre-antibiotic era, they used to treat things like scarlet fever or diphtheria with horse serum that contained a bunch of antibodies against those toxins. But after a week or so, some patients would start making antibodies against antigens in the horse serum. And those antibody-antigen complexes would deposit in the tissues and lead to fever, rash, and urticaria, arthralgias, and proteinuria. So again, nowadays we see drug reactions that cause a much milder form of this. And one last example is called an Arthus reaction. So this is a local subacute reaction where you give an intradermal injection of some antigen, such as a vaccination, and then the antigen-antibody complexes get deposited locally in the small vessels of the skin, and that leads to activation of complement and local edema and some tissue necrosis. Now, this Arthus reaction usually occurs 4 to 12 hours after the injection. So it's not as rapid as a type 1 hypersensitivity, but it's a lot more rapid than serum sickness, which takes several days to develop. And then type 4 hypersensitivity is T cell mediated. Now, there may be some antibodies involved, but ultimately it's caused by T cells. So T cells bind to antigens, and then they release cytokines like IL-2 and interferon gamma, and that activates macrophages that cause the tissue damage. Now, the two buzzwords I want you to remember with type 4 hypersensitivity are delayed hypersensitivity and cell-mediated hypersensitivity. So whenever you hear delayed hypersensitivity, I want you to think type 4. And remember that cellular immunity takes a while to get ramped up. It's not like type 1 where you have the antibodies lying around ready to go. With type 4, it takes time to present the antigen to T cells, then the T cells have to make cytokines, and then the macrophages have to be recruited. So it's a delayed process. So think about poison ivy. Poison ivy doesn't start itching immediately. It takes some time. Or think about the PPD skin test for tuberculosis. When do you read a PPD? About 48 hours after it was given. So some examples of type 4 hypersensitivity would include the PPD skin test, which we just mentioned, Hashimoto thyroiditis, which does involve several antibodies, but it's primarily T-cell mediated, multiple sclerosis, graft versus host disease, where you have a bone marrow graft, and then the T cells from the donor bone marrow end up attacking the host, and also contact dermatitis, which includes things like poison ivy or poison oak, and some types of latex sensitivity, although latex can also cause a true IgE-mediated allergy, or it could cause a type 4 hypersensitivity. It kind of goes either way. And you can also get contact dermatitis from metals like nickel or cobalt. The big clue for contact dermatitis from nickel is that you see it in areas of the skin that are exposed to nickel. So there might be dermatitis on the wrist from a watch band, or on the ears from earrings, or in this photo there's nickel in the button of the patient's jeans. Right where it's rubbing on the skin, he's getting a little contact dermatitis. So it's usually pretty easy to recognize. Now let's review these different hypersensitivity reactions one more time with a whiteboard review. In this review, I've listed a bunch of different diseases and conditions, and we're going to regroup them based on what type of hypersensitivity reaction each one represents. So we start with an acute hemolytic transfusion reaction, which is a type 2 hypersensitivity reaction. Acute rheumatic fever is a type 3 hypersensitivity reaction. Arthus reaction is another type 3 reaction. Asthma is a type 1 hypersensitivity reaction. A bee sting allergy is another type 1 reaction. And so is eczema. Graves' disease is a type 2 reaction. Guillain-Barré syndrome is another type 2 reaction. Graft versus host disease is an example of a type 4 hypersensitivity reaction. Hashimoto thyroiditis is a type 4 reaction. ITP, or immune thrombocytopenia, is a type 2 reaction. Multiple sclerosis is a type 4 hypersensitivity reaction. Myasthenia gravis is a type 2 reaction. Nickel allergy is a type 4 reaction. That's a type of contact dermatitis. Polyarteritis nodosa is a type 3 reaction. Peanut allergy is a type 1 reaction. Poison ivy is another type of contact dermatitis, so that's a type 4 reaction. Post-streptococcal glomerulonephritis is a type 3 reaction. Rheumatoid arthritis is a type 3 reaction. Seasonal allergic rhinitis is a type 1 reaction. And lupus is a type 3 reaction. I hope you got all of those right, and if you did, here's your reward. It's a smiley face made out of smiley faces. Now let's talk about complement. Thanks. I think you're brilliant and good-looking too. No. The complement system is basically a group of plasma proteins that work together to complement the actions of the immune system by opsonizing and killing pathogens and clearing them out of the way. Now, the good news is you do not need to memorize the entire complement pathway for step 1. I just want you to know a handful of key facts about complement. So first of all, you need to know the 3 pathways of complement activation and what stimulates each pathway. The classic pathway is stimulated by antigen-antibody complexes. Remember, one of the ways that type 3 hypersensitivity reactions cause damage is by activating complement. So that's the classic pathway. IgG or IgM antibodies bind to an antigen, and then they bind to a C1 complement protein and activate it. Then there's the alternative pathway, which does not require antibodies. So complement can be activated by molecules on the surface of microbes, or complement can spontaneously activate itself. There's also the lectin pathway. A lectin is a protein that can bind to a sugar. So in the lectin pathway, a specific lectin protein called mannose-binding lectin binds to a mannose sugar molecule on the surface of a microbe, and that kicks off the complement cascade. So definitely note those initial steps for each of those 3 pathways. Then the second point I want you to note is that the C1 is the starting point for the classic pathway. I already said that once, and you really need to know it. And there's a specific enzyme called C1 inhibitor that inhibits the cleavage of C1 into active components. And don't get confused, because C1 inhibitor also goes by the name C1 esterase inhibitor. The third major point about the complement pathway that you should know is the very last step, which is the formation of the membrane attack complex, or the MAC. So the MAC is the end product that you get from activating complement. The MAC is a complex of several complement proteins that get inserted into the plasma membrane of the cell one by one, and that creates a hole in the plasma membrane and it kills the cell. So the specific complement proteins that come together to form the MAC are C5b, C6, C7, C8, and C9. And those are worth knowing as the components of the MAC. So let's walk through a few more details about some specific complement proteins. C3b is important for opsonization, which is basically a process of coating pathogens so they're more appealing to phagocytes. It's kind of like dipping the pathogen in a chocolate fountain. It doesn't matter what the antigen is. When you dip it in that chocolate fountain, the phagocytes are more likely to eat it. That's particularly important when it comes to destroying encapsulated bacteria. So patients who are deficient in C3 are more susceptible to encapsulated bacterial infections. We also mentioned that IgG antibodies can opsonize pathogens. So C3b and IgG are the 2 most important opsonins. Then C3a and C5a play roles in anaphylaxis. To be more specific, C3a stimulates mast cells and basophils. And remember, we talked about how mast cells and basophils release histamine, which causes vasodilation and increased vascular permeability. That allows fluids to leave the vessels, and that can lower the blood pressure and lead to anaphylactic shock. And that vascular permeability also leads to edema and swelling of the larynx and the tongue, which is why the throat feels like it's closing up during anaphylaxis. And then C5a is also involved in neutrophil chemotaxis. And then again, the proteins that form the membrane attack complex are C5b, C6, C7, C8, and C9. Let's talk about some diseases in which the complement system doesn't work correctly. If there's a deficiency of the C1 esterase inhibitor, that causes hereditary angioedema. Now, we don't really understand how or why this works, but it seems to have something to do with elevated bradykinin. Angioedema in general is bradykinin mediated, and somehow C1 esterase inhibitor deficiency results in elevated bradykinin. And these patients should never take an ACE inhibitor, because ACE inhibitors also increase bradykinin levels and can cause angioedema as a side effect. Deficiency of C3 leads to recurrent pyogenic sinus infections and respiratory tract infections, specifically those encapsulated bacteria like Strep pneumoniae and Haemophilus influenzae. These patients also have increased susceptibility to type 3 hypersensitivity, especially glomerulonephritis. Basically, C3 is needed to opsonize and clear out those antibody-antigen complexes that cause type 3 hypersensitivity. So no C3 means more type 3 hypersensitivity. And then deficiency of C5b, C6, C7, C8, or C9 means you can't form the membrane attack complex. So a deficiency of any one of these, you're going to be more likely to have Neisseria bacteremia, and that could include either gonococcal infections or meningococcal infections. And there's also a deficiency of decay accelerating factor, or DAF, which is also called CD55. Now, DAF is a substance that helps protect your own cells from complement that spontaneously activated itself through the alternative pathway. So DAF deficiency leads to red cell lysis and a condition called paroxysmal nocturnal hemoglobinuria, or PNH. So take a look in your study guide, and let's talk about PNH for just a moment. PNH occurs in individuals whose red cells are deficient in two surface molecules that are involved in protecting the cell from destruction by complement and the MAC. The first is a glycolipid called GPI, or glycosyl phosphatidylinositol, which is a molecule that anchors various cell surface proteins to the plasma membrane, including decay accelerating factor, or CD55. The second surface molecule that's missing in these patients is called MAC inhibitory protein, or CD59, which also prevents the membrane attack complex from destroying cells. So if you don't have these two molecules, CD55 and CD59, you have complement-mediated damage of red blood cells. So your red blood cells are being attacked, they're being lysed by complement, and that leads to chronic intravascular hemolysis. And then the hemoglobin in the red cells ends up in the urine and causes hemosideриnuria and red-colored urine, which is the classic finding. Another unique finding with PNH is thrombosis, because platelets also get destroyed, and then they release their prothrombotic contents. Now, how do you diagnose PNH? Well, there are two tests to be aware of. Historically, we used a test called Ham's test, which is where you put the patient's red cells in acid, and if they lyse at a very low pH, that's a positive Ham's test, which is diagnostic for PNH. The more common, more modern way of making the diagnosis is to do flow cytometry. Flow cytometry allows you to look for the presence of CD55 and CD59 on the surface of these red cells. So if you do flow cytometry and you don't see those surface markers on the red cells, that suggests a diagnosis of PNH. Then how do we treat it? These patients may need transfusions because they're undergoing hemolysis. We anticoagulate them with warfarin because they have that increased risk of thrombosis. And there's a drug called eculizumab, which is a monoclonal antibody that inhibits complement and prevents it from attacking the red cells. But eculizumab costs several $100,000 a year. Now we're ready for the end of session quiz. So pause the video and work through those questions, then we'll talk through the answers together. First question, which type of hypersensitivity is responsible for each of the following clinical problems? So post-streptococcal glomerulonephritis is a type 3 hypersensitivity, asthma is a type 1 hypersensitivity, rheumatic fever is type 2, the TB skin test is a type 4, allergies, anaphylaxis, and hay fever are type 1, polyarteritis nodosa is type 3, serum sickness is type 3, ABO blood type incompatibility is type 2, poison ivy is type 4, eczema is type 1, contact dermatitis is type 4, and Goodpasture syndrome is type 2. Next, the patient suffers from recurrent Neisseria infections. What complement proteins are deficient? So this could be any of the membrane attack complex proteins, C5b, C6, C7, C8, or C9. And the last question, which complement is responsible for neutrophil chemotaxis? That's complement C5a. That's it for this video. I'll see you next time.